hopefully this is the final teaching session, and it will just encompass everything that we've learned, or just a brief recap of every topic, just to make sure everyone's aware of the kind of high yield information that will be assessed on the Duke Elder. Okay, so well done for getting this far, and it's so nice to see so many returning names and faces. Okay, so no pre-teaching quiz, thankfully, today, so you'll be glad to know, everyone. I've talked about this before, where once again, this is near peer teaching, so we don't always have it right. It's free for that reason. We are all trying to help as much as we can, and we've all got a passion for medical education. So if there's any comments or any worries about anything, always just let us know and we'll try and address them. And by addressing them, we usually tend to just do a lot of Googling, okay? But the aim of this course is to help you pass, give you the foundation of the knowledge, and once you've built on that, you can, in subsequent years or in future exams, use it and build on it further, okay? So that's the whole goal of this course. So this lesson's a bit of an unusual one. We're going to recap all 8 other webinars, okay? And I do mean a recap, so we won't go into too much detail. I'll try and provide the high yield information more than anything. We'll then talk about evidence that the evidence that underlies ultimately revision and passing exams, and the way you should study for future exams if you aren't already aware of it. If you've got a good system, then feel free to ignore this section. It'll be hopefully rapid. We'll deliver some last minute advice on how to tackle the exam questions in the MCQ style. Some resources for learning for further kind of part 1 / Duke Elder prep if you happen to sit it in other years, and just some brief advice on applying to ophthalmology, okay? And once again, unfortunately, you won't see much of this in the actual curriculum for Royal College of Ophthalmologists. This is more of a recap, and everything else is supplementary. All right, I was quickly check. I'm the only one here today, so I don't actually have an eye on my chat, sadly, but hopefully we're all golden. We've got some prism informations. PB, thank you for clarifying, mate. Okay, so to recap on the 8 webinars we've had so far, we'll go through them individually, and we'll have 2 to 3 slides on each individual topic. So first one was on the anatomy of the eye. Now, when it comes to the anatomy of the eye, the high yield stuff tends to be the anterior segment anatomy, just because unfortunately there's not really much behind the eye, the vitreous, the middle parts, and the retina, knowing all the layers, I think is a bit of an unfair question. I've not seen it crop up personally, but they might ask you about the specific kind of high yield retina layers. So most of the juicy anatomy that they can test and would like you to know, I think, is usually anterior more than anything, okay? And by anterior, I usually mean kind of the posterior caps of the lens forward, okay? Anything beyond that point. So we're going to review the cornea in this slide. The cornea kind of, there's a mnemonic, you can use A, B, C, D, E to remember it if that helps you. But a good way to just remember it is the fact that you have the outer cornea. And so here you'll have basically a protective layer of epithelium. So you've got the corneal epithelium at the very surface, which is kind of initially kind of stratified squamous, okay? That's non-keratinized, okay? And then it kind of eventually forms small little cuboidal chaps down here at the bottom. So stratified squamous because you can shed the cells as much as you'd like. And then we transition to slightly more kind of cuboidal shaped cells. So that's the anterior cornea, and it's a protective layer against abrasion, as well as hosts the tear film at the very anterior surface. All right. Then you have Bowman's membrane. Now, Bowman is just a chap who discovered it, and the membrane itself is a basement membrane. So if you recall from your histology knowledge, every epithelium has a basement membrane that it attaches onto. It's the structural support. So if there's an epithelium, you'll always find a basement membrane. This one just happens to have a name known as Bowman's membrane. Then we have the stroma. This is the transparent, non-vascular, and rich in nerves part of the cornea. This is the majority of the cornea. About 95% of light goes through this part and transverses into the back of the retina, hopefully to reach it. Only 5% gets absorbed, And then there's an interesting fact where the fibrils, I think in the anterior 2/3, are arranged in a kind of horizontal fashion, whereas the ones slightly posterior in the posterior third have an oblique fashion. And that's usually quite a kind of an easy question to answer. So these are the collagen fibrils. Otherwise, the stroma is well ordered to make sure that it's transparent, okay, and not opaque. So it's not like a meshy work, it's more kind of ordered fibrils, okay, to allow for transparency. It's painful to have a corneal also because of the fact that it's rich in nerves, but it's avascular ultimately. So there's no vessels traveling around. So most of its nutrition actually comes from the aqueous humor, okay, which is in the anterior chamber. Just like we have an epithelium here, down here, we have an endothelium, okay? This is usually a single layered endothelium with usually cuboidal to slash columnar cells, but mostly cuboidal cells, which are highly active and energetic, and they pump ions back and forth between the aqueous humor and the stroma to feed it. So this is very highly metabolically active cells. They're cuboidal in nature, and they just like Bowman's membrane, they also have a basement membrane known as Descemet's membrane. These cells don't regenerate, sadly. So if we start to lose endothelial cells due to genetic reasons or due to trauma, or sometimes some of the core glaucoma implants we put into the eye might abrade these cells, that's it, they're gone. We can't replenish them, sadly. So that's the cornea. I'm sorry, it's going to be very scattered, 2-3 slides per topic, but the stuff that's high yield is what we're going to focus on. So next we have the visual pathway, all right? So the visual pathway is quite easy to ask questions on, especially due to the lesions that they might say that have occurred. So they'll name a structure saying there's a lesion to, for example, the optic nerve. What kind of visual field defect does that produce? Okay, so pardon me. So in the case of a optic nerve lesion, you'll have unilateral field loss, okay, or monocular blindness. Or if there's a problem with the retina, you might also have monocular blindness, so like a retinal detachment. That's the type of basically one part of the vision doesn't work, monocular blindness or unilateral field loss. Chiasmal lesions, depending on where they come from, if it's a craniopharyngioma, for example, which is coming from, gosh, do they come from above? Sits on pituitary tumor sits. Okay, so they come from below. Apologies. So embryological lesions, okay, like a craniopharyngioma that comes from below, will usually create a supra deficit. It'll be a bitemporal hemianopia, which means both the temporal fields are lost, but it will be a superior deficit. Whereas if it's a pituitary tumor that sits on the optic chiasm, so it's coming from above, the lesion will be inferior deficits, okay? And that's because it's counterintuitive, but it's because when the rays fall on the eye, they fall on the eye kind of like that, and they decussate before they hit the retina. So basically the image is reversed, if that makes sense. So that's the type of visual field defect that you'll get in this particular region around the optic chiasm, okay? So no matter what the lesion here is, it will always produce a bitemporal hemianopia, but you've got to think about if it's coming from below or from above, depending on which part of the quadrants it will affect. So it might start to affect the supra or inferior quadrants first. A homonymous hemianopia is one of your 1 in 3 stroke syndromes, okay? This is a very, very red flag sign. So any patient who presents with a homonymous hemianopia, you need to start thinking at the back of your head if there's a potential stroke, because this is one of the major symptoms for either a total anterior circulatory stroke or a partial anterior circulatory stroke, okay? And that's essentially any lesion that's beyond the optic chiasm, okay? So number 4, that's a homonymous hemianopia, okay? And it can either be on one side or the other side. So you can be either unilateral, and it will usually be contralateral to the site of actual lesion, if that makes sense. So if it's right-sided lesion, or if the stroke's on the right side of the brain, then the visual field defect will be on the left side, only because this optic tract is carrying the fibers from the left side of vision, if that makes sense. So they all decussate here. And the same with this one. If you have a lesion on the left-hand side here, the homonymous hemianopia will be on the right side, contralateral, all right? Then you have to think about if the lesion is beyond the optic chiasm and we have a homonymous hemianopia, sometimes we have the radiations, okay, the optic radiations. We have to think if we're having a lesion superior or inferior. Once again, similar to the optic chiasm, a superior lesion will usually lead to an inferior quadrantenopia, whereas an inferior lesion usually leads to a superior quadrantenopia. And this is because of the way that things happen in the initial refraction process when it reaches the eye. The image is not only made upside down, but it's also inverted, okay? So that's what happens beyond here in the radiations. And then typically if there's a cortical lesion in V1 or any of the associative visual cortices, okay, so sometimes it communicates with the parietal, the temporal lobes, which are known as V2 to V4. There is up to V6, apparently in some of the literature. Then there'll be different areas of macular sparing, basically, but you don't need to go into too much detail. So if there is a V1 to V6 lesion, there will often be a very unusual kind of scotoma formed in the actual kind of hemianopia, okay, if there is a cortical lesion, all right? So that's the visual field. It's very easy to test. And then finally, the last high yield topic is the extraocular muscles, okay? Unfortunately, I'm sure some of you have a much better way of learning this, but I can only rote learn this myself. So the way I do it personally is I do remember this silly cartoon that I used to watch as a kiddo, okay? And I tried to make a mnemonic known as Sinrand or Babinix, okay, just based on Sinbad. And ever since then, I've just tried to work out this table if I have the time to work out the exact movements that they're asking me that are either secondary, tertiary, or primary, depending on the muscle. So this mnemonic states superior recti intort. Okay, so you basically draw out this table in every exam. Okay, at least I do. The superior muscles intort, so your superior obliques and your superior rectus do intorsion as their tertiary movement. The rectus muscles adduct, okay? So inferior rectus and superior rectus are the only rectus muscles on this table, so they do adduction. The oblique muscles abduct, so abduct, so superior oblique, inferior oblique abduct. And then the inferior muscles, okay, inferior rectus and inferior oblique, they extort, so extort. So once you've got your secondary and tertiary movements worked out, you can basically by first principles work out the primary movements. These I do know without a mnemonic. So the rectus muscles tend, in terms of respect to primary movements, obey the rules of what they kind of say they do. So a superior rectus muscle will always elevate, and inferior rectus muscle will always depress, okay? However, the obliques, in terms of their primary movements, don't tend to obey their kind of the way they're described, if that makes sense. So a superior oblique will counterintuitively depress despite being superior attachment, and inferior oblique will counterintuitively elevate despite being described as an inferior muscle. Do you see what I mean? Okay. And then the lateral and medial rectus only do one primary movement. And for the medial rectus, that is abduction, so towards the nose. And the lateral rectus will do, sorry, medial rectus does adduction, so towards the nose. And the lateral rectus does abduction, away from the nose or towards the temporal visual fields, okay? Another mnemonic to describe the innervation. Every muscle is innervated by the oculomotor nerve, which is cranial nerve 3, unless said otherwise, but this is the exceptions. Superior oblique is innervated by 4, and lateral rectus is innervated by cranial nerve 6. Okay, so a busy slide, but I guess the important part is if you remember this, or if you have a better way of remembering how extraocular muscles move, unfortunately, this is the only way that sticks with me, then I'm able to recreate this table and essentially reel out secondary, tertiary, and primary movements of muscles. All right. Hopefully that makes sense, everyone. I can't actually see the chat, sadly, so, but I'm happy to answer any questions towards the end of this talk, okay? So Lesson 2. So the high yield ones for anatomy are know your rectus muscles, know your visual pathways, and know your anterior segment anatomy, because those three are very high yield informations when it comes to anatomy. But overall, anatomy is a very big topic and is very high yield for the Duke Elder. So pharmacology and physiology, which was lesson 2. So once again, we're going on this concept of the anterior segment being very important. Here are a few facts that sometimes get asked, or a few specific digits or kind of values that get typically asked around these around the anterior segment. Okay, so you have the cornea. It has a refractive index of 1.36. Okay, it is not as thick at the center compared to the periphery. Okay, 0.5 compared to 1 millimeter, and as we described before, it has innervations from the trigeminal nerve, but the ophthalmic branch, which is V1. Okay, just park these facts in your head if you can. The stroma, it is 50 micrometers thick. 98, sorry, I said 95 earlier, but 98% of light is transmitted fully through it. Okay, nutrients and oxygen is derived from the aqueous humor, so its nutrition is supplied by the diffusion process based on the endothelium. Okay, no, through the active transport process based on the endothelium. And the anterior third, the collagen fibrils, are arranged in an oblique fashion. Okay, oblique just meaning kind of an in-between between horizontal and vertical, and the posterior 2/3 are arranged in a parallel fashion. So it's quite a highly ordered connective tissue. Okay, the endothelium has active pumps to maintain the integrity of the cornea and supply nutrition to it, as well as pump out water if it ever gets insulted by corneal edema. It produces Descemet's membrane because every epithelium or endothelium has a basement membrane usually. And it does not regenerate following trauma, which is important because once you start to lose endothelial cells, that's a ticking time bomb, okay, for your vision and your cornea. You'll eventually need a corneal transplant. The lens, it's 3 times thicker than the posterior segment. So remember how Razor talked about the lens being like a M&M peanut, okay? It has an outer sugary coating, then it has the chocolatey thing, and then it has the nut on the inside. So the capsule is the outer sugar coating of the lens, and it is 3 times thicker anteriorly compared to the posterior. So 12 micrometers anteriorly and 4 posteriorly. It thickens with age due to crystallins, which are present, and they start to basically with time get glycosylated and oxidized. Oh, sorry. And the tears have antibacterial properties due to specific immunoglobulins, lysozyme, lactoferrin, and beta lysine, okay? And they're highly concentrated in chloride and potassium ions, all right? Okay, the physiology. This is a bit difficult, but let's work through it. So we have stuff that controls the aperture of our pupils, okay? So it's like a camera, right? There's an aperture, and this is known as the pupil. So we have the radial muscles, okay? We have the circular muscles that surround the pupil directly, and we have the radial muscles, which are like a bit like a bike spoke appearance, okay? So they do the stretching, and these circular muscles do the contracting, all right? So this is a normal pupil at baseline, okay? And then these pupils have different parts of the autonomic nervous system acting upon it. So the parasympathetic, okay, is responsible for meiosis, which is constriction of the pupil, making the aperture smaller. Remember, the way I remember it, unless you're a Latin scholar, I have no clue. Meiosis is smaller as a word, so it's constriction. Myodrisis is a longer word, so it's dilation, okay? So that's how you can sound fancy in front of your colleagues, okay? So meiosis makes the pupil smaller, and it's primarily the circular muscles contracting, which are under parasympathetic innervation. However, if you want to make the pupil larger, okay, just like it looked like you're under the influence of crack or heroin, okay, you have the sympathetic fibers acting on the radial muscles and tugging open the pupil, okay? So radial muscles contractions leads to dilation, circular muscle contraction leads to meiosis. The clinical significance of all this stuff is interesting because various drugs can influence these systems to give you this kind of look, either miosis or myidrasis, okay? So before surgery and some complex cataract surgery, we tend to reduce the pupil size if the fibrils, for example, are very loose or there's loose zonules. We tend to give phenylephrine, okay, prior to cataract surgery to let the pupil become, hang on, phenylephrine is a sympathometic, sorry, pupil to dilate the pupil. Apologies, phenylephrine is not the drug that's given for zonule weakness. Phenylephrine is a drug given so you can increase your field of view when you operate. So you can see the capsule bag fully and you can have your phaco tool reach the peripheral kind of parts of the cataract. So phenylephrine might be used to increase your surgical view rather than what I talked about earlier, okay? Cycloplegics, okay, they basically induce pupillary dilation and they lose accommodation, which we'll talk about here, because they mimic, because there's the sympathometics, so they mimic the sympathetic nervous system, okay, and they essentially induce dilation through blocking the parasympathetic. So if that makes sense, this is a direct agonist, okay? Phenylephrine is an alpha/beta agonist, whereas atropine and cyclopentolate are anti-muscarinics. They basically block the parasympathetic, but in the process of doing that, they encourage the sympathetic nervous system. So that's why we call them sympathomimetics. They mimic the sympathetic nervous system, and they have the same outcome as phenylephrine in the end, but a different mechanism of action. So atropine causes a dilation. So atropine used to be used by Asian culture in way in the back past kind of history, because dilated eyes used to be considered more appealing in terms of kind of women used to think they were much more beautiful. So atropine used to be used as a dilating eye drop to potentially make women look better in terms of their eyes, but it had many side effects. Cyclopentolate is a bit more selective, and it's used as a cycloplegic to help uveitic patients stop the iris spasming and the muscle spasming. So if they've got ciliary body kind of inflammation, it helps stop spasming. Okay. In terms of accommodations, so the ciliary body and its zonules, so this is an image of the ciliary body. Sorry, this is the lens, apologies. You have the lens zonules, okay, these little kind of suspensory ligaments that are attached to zonules that are attached to the ciliary body. These dictate accommodation. And what I'm trying to indicate with this diagram, unlike these muscles, accommodation is not under sympathetic innervation, okay? It's only under parasympathetic innervation. But the way we get accommodation to work is essentially the parasympathetic system will either upregulate its tone, and by upregulating its tone, it causes the ciliary muscles to contract, and the suspensory ligaments, as a result of the ciliary muscles contracting, actually relax. Okay, let me just make sure I've got that right. So suspensory ligaments relax and the lens fattens, okay? And as a result, we start to become short-sighted. No particular reason why, but it's a bit like watching TV, I guess. So if you're parasympathetically, you're digesting, rest and digest kind of, think about watching TV and you need your short-sighted vision to watch the TV or read a book, okay? Whereas if the parasympathetic turns off its kind of pedal in terms of tone, so if it decreases its tone, then the ciliary muscles start to relax, and by relaxing, they elongate, and by elongating, they kind of tighten up the zonules, okay, and we get a slightly thinner lens, okay, designed for more long-sighted vision, okay. So this is more for fighting off predators that are in a distance, okay? So you can see long-sightedly fighting off predators, and it's more of your kind of fight or flight response. But it's not under sympathetic innervation, it's under parasympathetic innervation, but the tone has been decreased, okay? And the reason this is important clinically is because pilocarpine, okay, which is a muscarinic agonist, is a mimicker of the parasympathetic nervous system. So, oh, there it says it, muscarinic agonist. And we use pilocarpine to dilate eyes. And so in the process of basically essentially inducing myidrasis, okay, it also is able to give the accommodative effect of the lens, okay, because it's a muscarinic agonist. And that's why patients are advised after dilating eye drops, hey, please don't drive anywhere after this procedure because you might crash. You're only designed for short-sightedness. So you won't see oncoming cars at T-junctions or over the motorway, okay? So that's that. The autonomic supply of the eye is very important in the high yield information, okay? So learn the exact autonomic supply of the eye. The next important part of pharmacology is aqueous dynamics, okay? And hopefully we've discussed this, hopefully at depth within both pharmacology lesson and the glaucoma lesson, but let's do a quick recap. Ciliary bodies produce aqueous humor. The aqueous humor travels from the posterior segment of the anterior chamber, okay, the posterior segment. It bypasses the lens and it slowly diffuses forward into the anterior chamber to be then sucked in by the drain at the trabecular meshwork, okay, and to be taken into the Schlem's canal and drained out. That's about 90% of flow, and it's known as trabecular flow mechanism, okay? The other 10% goes via the uveal scleral flow, and that's essentially the kind of scleral and the uveal tissue soaking up any leftover kind of aqueous humor and it being kind of discarded in that way, okay? So it's kind of happening passively everywhere, okay? Whereas the trabecular meshwork has a very clear direction to it, okay? And why this is important is essentially a lot of drugs work to increase the uveal scleral outflow or the trabecular outflow, okay? Other drugs in glaucoma block the production of aqueous humor by acting on the ciliary body, which carries specific autonomic receptors, such as alpha-2 receptors and beta receptors, okay? So this brings us on to the glaucoma medication, okay? So stuff that acts on the uveal scleral outflow, such as adrenaline, probably never used as a drop in itself, okay, because it has too many systemic side effects, okay. Then we have stuff that increases trabecular outflow, such as the prostaglandins, which are first line, and the parasympathetics, which aren't first line, because once again, many side effects. You can't pee, you can't see, you can't climb a tree, and you have dryness, etc. So many side effects with the parasympathetics. Prostaglandins, though, are first line according to NICE guidelines, like latanoprost, but they have other kind of side effects that you should know about if you can. Then we have other medications that act on the ciliary body through alpha and beta receptors, okay, such as timolol, okay. Topical timolol is also quite commonly used as a first-line medication. Alpha-2 agonists, okay, apraclonidine. And then we have carbonic anhydrase inhibitors, which unfortunately, once again, carry many side effects systemically. They're used as usually second or third line, or they're first line in acute angle closure because they can be given intravenously to very urgently decrease aqueous production, okay? But these primarily all work on the ciliary body and tell the ciliary body stop producing aqueous, whereas the ones that increase aqueous flow work via the trabecular outflow mechanism, unless we're talking about adrenergic agonists, which are rarely used or seen, but they might be used in surgery. Okay, I'm really sorry for this whistle stop tour, guys, but you're doing super well, okay? Well done. Lesson 3, infectious diseases of the eye, okay? The anterior segment, once again, our favorite segment, but please, please, please don't forget that the anterior segment is not just the eye, but also the adnexa, okay? Once again, a fancy term that we use to describe the bits and bobs of anatomy that surround the eye, okay? Including the eyelid, including the lacrimal system, okay? So don't forget about them, as well as the surrounding skin and tissue, okay? So let's talk this through. Here we have a stye, okay? It is usually painful, it's usually a solid lump, and it's a blocked gland, okay? Then we have blepharitis, okay? This is usually gritty eye sensation. It's a spectrum of disease, but it's usually gritty eye sensation. You've got these dandruff appearance to the eyes or the eyelash follicles, okay? And the patient usually has blurring of vision because of the fact that it's kind of a gritty sensation, and so their eyelids shut, okay? That's how blepharitis tends to present. We then have a differential for another lump of the eye, a painless hard eyelid lump. I think this is a meibomium cyst, okay? It's painless compared to a sty, which is painful, okay? This is a blocked meibomian gland, which can potentially become infected, but usually is occupied by just basically normal meibomian secretion, okay? And it's just blocked because usually there's an underlying dry eye disease problem, okay? There's no exit out because of the blockage of the kind of these little dandruff materials. So that's why this can get blocked itself. And that's why very commonly ophthalmologists will say to patients, can you do hot compresses, hot eyelid compresses? And that's where you get a bit of humid water, okay, that's kind of room temperature, and you pop it onto the eye and you unblock this gland, okay? Compared to this will usually require antibiotics because of the fact that this is a also blocked meibomian gland, but there's usually folliculitis on top of it, as well as an infection that's brewing, okay? Here we have canaliculitis, okay, and this is dacrocystitis. The reason these two differ is just purely on anatomy. So canaliculitis, okay, is inflammation of the canaliculus. In this case, we have the inferior canaliculus being inflamed. If you were to squeeze, then you'd get stuff that comes out. These are usually managed conservatively. There's no need for surgery. And if it really gets affected for the adnexal kind of tissue, then you might give antibiotics. Equally, dacrocystitis, although they look really awful, they usually are self-limiting. They usually drain for a punctum that's created superficially or through the canaliculus, but often there is an obstruction somewhere, either proximal or distal. This is why this usually forms, and it's usually a swelling of the actual lacrimal gland rather than the canaliculus, all right? So this is the lacrimal gland, sorry, not lacrimal gland, the lacrimal sac, apologies. The lacrimal gland is up here, situated up here in the 2 o'clock position, okay? So this is usually the lacrimal sac, the drainage pipe work that usually gets infected. And then hopefully this you guys all recognize, but this is orbital cellulitis. It's a better diagnosis made when you can actually open up the eyelid rather than just looking superficially, because your differential for orbital cellulitis might also be preseptal cellulitis or just periorbital cellulitis, okay? The skin outside might be just inflamed. Preseptal cellulitis and preseptal cellulitis and periorbital cellulitis are less of emergencies compared to orbital cellulitis, okay? So here, this is an emergency. The reason I've highlighted a recent upper respiratory tract infection is because usually it's due to sinusitis. 90% of cases have underlying sinusitis. So they might have a sinusitis headache, okay, which is worse going forward. Nose is congestion, there might be discharge, there might be a bit of a dry cough, all right? Orbital cellulitis, this is an emergency, okay? IV antibiotics if the child's very ill, and it usually occurs in the pediatric population rather than an adult population. Okay, posterior segment, gosh, loads to go on here, but in essence, and I can't remember the exact signs for some of these, but you need to know the specific descriptor term that's used for specific pathognomonic conditions, okay? For example, CMV retinitis, I can't remember the descriptor term, to be honest, guys, so I'm gonna have to excuse myself from this, but for example, Candida retinitis, you've got pearly white beads, for example, that's how it usually is described. And so as soon as you see that as a question, you start to think, okay, Candida infection. Catch scratch disease or retinitis usually gets described as I think a stellate appearance. So you've got this kind of stellate appearance, okay? A central lesion with all these kind of stellate-like off projections. Toxoplasmosis usually gets described as, I think it's a light at the end of a tunnel or kind of the light in the dark, etc., because you've got basically a very big lesion of translucency, and then you have this necrotic retina around it. Peripheral something retinopathy, so I apologize about all this, but peripheral something retinopathy usually is caused by hepatic lesions, okay? And so you get these kind of soft woolly spots, yellowy in nature, that kind of diffuse, okay? And then sarcoidosis, you get these punched out darker lesions that usually occur at the peripheral retina, okay? So the main point of this slide is to remember the pathognomonic terms that associate with the specific condition, especially with retinopathies or retinitis, okay? Chorioretinitis. Okay, uveitis, systemic disease. The high yield topics here are unfortunately the actual systemic diseases, okay? Not the ocular signs, which you should know, hopefully, but the systemic diseases and how they present. So especially the focus is on the HLA, the seronegative HLA-B27 arthropathies are very characteristically described, and Behçet's disease, which fits under a different HLA molecule, which is HLA-B51. So they can very easily in questions ask you about the specific HLA molecules, okay? And they quite like doing that. This is just a table that describes the various types of conditions, infectious and non-infectious, that cause uveitis. I know the list is long, but it's just worth knowing 2 to 3 examples in each and how they might present both systemically as well as ocular symptoms. So for example, with herpetic infections, they might show you a retina and that's characteristic of a herpetic infection, such as this one, okay? And they might say this person's presented with this fundoscope and they have, say for example, genital lesions that are painful. What is the most likely diagnosis, okay, or etiology, for example? So focus on the systemic conditions, be aware of how they present, like Angst-Spond, Behçet's, dry mouth, dry mucosal tissue, IBD, loose bowel movements, blood, JIA, pediatric group, monoarticular, polyarticular, sarcoidosis, progressively worsening kind of shortness of breath. Think about endemic countries. Seronegative arthropathies, okay, so they'll have changes in their hands, for example, in reactive arthritis, psoriatic. Angst-Spond tends to affect their spine. They get kind of gradual kind of kyphosis, and IBD affects their bowels. And Behçet's tends to present with mucosal lesions, dryness, and from a Mediterranean background, I think. So all this stuff, remember. In terms of the actual uveitis, they tend to focus either on retinal photographs of posterior uveitis, as we showed earlier on, or they'll ask you for specific signs that you might see on anterior segment examination for anterior or intermediate uveitis. So don't forget about when you've got your immune cells, they rush into the anterior segment of the eye. They'll often leave little clumps of stuff around, okay? And that explains all these symptoms that you might see. So precipitates deposit, okay? If they're acute infection, then they'll get keratic precipitates, little small ones that are white in nature. But if it's a chronic or granulomatous condition, you tend to get mutton fat precipitates. These are clumped together cells, okay? And they look a bit less white. They're more greasy, yellowy, darker, kind of scales of gray, etc. Cells and flare are the actual cells and debris that's found within the anterior chamber. There's a grading known as the sun grading system, okay? You will also get synechii, so sometimes you might get small or irregular pupil sizes because of these kind of sticky adhesions that are formed by the iris. You get peripheral anterior synechii, which can block the drainage angle. They're usually found on gonioscopy, remember looking at the drainage angle. Or you can get posterior synechii, which are usually formed on the back of the iris, and they adhere to the anterior capsule of the lens, causing a sticky iris and spasming. So to these people, you usually give cycloplegics to calm down the iris, and it relieves a lot of pain for these uveitic patients. And photophobia is because the aperture is not doing its job. And so when the eye becomes sticky or the iris becomes sticky, sometimes too much light might be coming in. And so these patients rock up to clinic with glasses, okay, because too much light is coming through. And then if there are inflammatory cells that still lie dormant within the eye, they might actually embed themselves in the iris and they form these nodules. Koper nodules are usually, gosh, where are they? Precipitates that lie in the pupillary margin. So they're quite close to the pupillary margin, whereas Bisaka nodules tend to be kind of all over the iris surface and less pupillary. These are more pathognomonic for granulomatous uveitis. So TB in origin, sarcoidosis in origin, okay? Good. Neuro-ophthalmology, guys, we're almost there. I'm so sorry. This is a chunky guy. I did not expect this. For neuro-ophthalmology, you need to know about your syndromes, okay? Neuro-ophthalmology, you need to know your syndromes, your cranial nerve palsies, and your pupillary responses, okay? Or pupillary defects, if that makes sense. So for Horner's syndrome, there's a very good mnemonic known as, I think Pamela is horny, but the main cardinal signs, Pamela being the mnemonic, but the main signs is you get a partial ptosis, okay? you get miosis, a small pupil, and you get this kind of reported reduced sweat. Other signs you get are enophthalmos, which is actually a theoretical sign. It's not seen. And enophthalmos, I mean, the eye kind of goes back in on itself. It's a very theoretical sign, okay? I don't think many people describe it. And then there's another sign, but I can't remember it. And Pamela is usually the mnemonic that people use. So know your signs for a Horner syndrome and appreciate how it's different to a cranial nerve 3 palsy, okay, with a partial ptosis, miosis, okay? These are the two differentiating signs to a cranial nerve 3 palsy. And appreciate that Horner syndrome can basically have a lesion anywhere along the primary, secondary, or tertiary neuron, okay? Primary usually is CNS disease. So here's a list, okay? There's loads more, I'm sure there are. MS might be included. Then you have a secondary order neuron disease. This is where the interneuron is letting off its signal through the synaptic chain to the kind of postganglionic neuron or the tertiary neuron. And these are usually affected by lung lesions, such as Pancoast tumor, or aortic lesions, sorry, carotid lesions, apologies. So if there's a dissection or carotid aneurysm, okay? And then the postganglionic or tertiary neuron lesions are usually kind of a whole array of stuff. So they can be either stuff that's still within the head, okay? So sometimes you might get, for example, cavernous sinus syndrome. You can also get internal kind of artery occlusions or dissections. It also traverses not too far from the ear, so ear pathology can also affect it. It also traverses through the facial muscles, so sometimes nasopharyngeal tumors or anything like that can affect it. And in some cases, there's this autonomic phenomenon with certain types of headache pathology, such as cluster headaches or migraines, that can cause a mimicry for Horner syndrome. All right. So know the signs and know that there are 3 types of places for lesion hunting, okay? Other syndromes that you need to be aware of, okay? I'm not going to go through, sadly, the signs and symptoms of each cranial nerve palsy, but just be aware of the classical signs, okay? Cavernous sinus syndrome, it depends on, once again, this is all anatomy heavy. You need to know your intracranial anatomy to appreciate why these lesions occur and knocks out which types of nerves. But cavernous sinus syndrome, so if you've got a clot or enlarging venous sinus here, it will knock out basically the nerves that travel through here. And that's primarily 3, 4, and 6, the nerves that do movements of the eye. Okay, so you have ocular motility issues. You'll also have headaches because you've got a potentially space occupying lesion that's affecting this cavernous sinus. And you'll get chemosis, which is forward projection of the eye, or exophthalmos. Okay, once again, because there's a space occupying lesion. Orbital apex syndrome is when there is essentially, it's usually formed due to trauma, okay? It's usually a hematoma that's built up at the back of the orbit, okay? Remember that the orbit's a pyramid and there's nowhere else for the eye to go apart from forwards, okay? So if blood, for example, builds up there due to trauma or an injury to a vessel or a dissection that's forming there due to a small vessel dissection, then you'll get knockout of all the nerves that go through that kind of little foramen. Not, they all go through different foramens, but through that kind of little initial segment of anatomy before they spread into their foramen, okay? So that's the optic, the nerves to do with muscle movements, ocular movements, which is 6, 4, and 3, as well as the ophthalmic branch of trigeminal. Superior orbital fissure is one of the foramens where a lot of nerves travel through, but it's not quite the apex of the orbit, okay? So here we're starting to get a bit of a division again. So 3, 4, and 6 are the nerves to do with ocular movement, and the ophthalmic branch go through superior orbital fissure. But similar causes can arise between these two, okay? Trauma and hematoma formation. Ocular myasthenia, okay? Typically fatigability improves with rest, and then we have these fancy tests that we can block the enzyme that chews up acetylcholine, okay, like edrophonium, and we can actually relieve the fatigability or the ptosis. So this is typically bilateral ptosis presentation, all right? And it's formed due to an autoimmune response against the receptors, all right? This is orbital apex syndrome, I believe, here. Please don't ask me what I'm seeing here on anatomy, but basically you get a protrusion of the eye. They'll have ophthalmoplegia, meaning all the eye movements are painful, and they also won't be able to move this eye. It's going to be completely stationary and fixed, all right? All right, pupil syndromes, okay, pupil problems. So anisocoria, once again, we use complicated fancy terms to deceive our patients, but it essentially just means the pupil sizes are different between the two eyes. Don't always go hunting for a cause, a neurological cause, because 20% of people on this planet will have physiological anisocoria, meaning that it's normal. And you typically tend to find these people, their anisocoria tends to worsen in the dark, as well as it tends to be a bit of a smaller difference between the two eyes. And I can't remember the exact measurements, but I think 0.1 millimeter or less, you tend to point towards physiological anisocoria. Other forms of pupil abnormalities that you should be aware of, Adie's tonic pupil. This is usually a single large pupil, such as this. This is an Adie's tonic pupil, normal eye, slightly larger pupil, and this is due to a parasympathetic lesion. You get this dissociative effect, basically, where it can't constrict to light, okay? So the parasympathetic and sympathetic nervous systems are somewhat affected. However, you can accommodate. And remember, we talked about the fact that a parasympathetic lesion is the only thing that's supplying the accommodation reflex. So it's slow to constrict if there's a partial parasympathetic lesion. Other causes of a differential for a large pupil that's unilateral in nature include angle closure, mid-dilated pupil, and third nerve palsy when the pupil is reported to be blown, okay? That's because the autonomic fibers are being compressed. In terms of other syndromes, we've talked about Horner's. You get meiosis, small pupil. It's a sympathetic lesion classically. And then you have certain tests that you can do with a Horner's to reverse it. So aproclonidine, which is a sympathomimetic. So it makes sense if the sympathetic nervous system is no longer delivering noradrenaline at that synapse. You have a mimicker, aproclonidine, which can reverse the Horner's, okay? And pilocarpine, if it's a true Horner's, which is a parasympathetic, will not dilate the Horner's, okay? So complex autonomic drugs come back to haunt us in these kind of tests that we do. So that's why we need to know them like the back of our hands. And other causes of a single small pupil include anterior uveitis, and this is because of synechia. So usually the iris sticks and gets sticky. Bilateral pupil changes, okay, this is important also. So this is all unilateral pathology, include headache syndromes. So like migraines, cluster headaches can sometimes present with bilateral changes. I think cluster headaches less so, migraine, because it's vasospasm and sometimes. Pharmacological drugs, okay, trauma, and in this case, Argyll-Robertson, which is bilateral small pupils. Argyll-Robertson used to be, the major cause for it used to be, for example, neurosyphilis in prostitutes. And so that's why the saying goes, they can accommodate, but they don't respond to light. So they're accommodative, but don't respond to light, okay? It used to be a common thing. Neurosyphilis used to be the major cause, but these days, I think there's other theories that are going on as to why people have bilateral small pupils, all right? Good, pupil syndrome's done. Pediatric squints and genetics. I'm just going to cover some definitions here. So just because this isn't my forte, sadly, but the popular things that they like with pediatrics is usually testing how you would test visual acuity in peds. They also like eye development and by what time and what age it forms fully, certain structures, for example. And they do like there are different types of definitions. So they might show kids with, for example, certain types of squints or lazy eyes, and they want you to be able to identify whether these are hypotropias, hypertropias, exotropias, esotropias, etc. So a squint is basically a fancy term, strabismus is a fancy term for a squint. There is essentially a malalignment of the two eyes, okay? I think someone asked this question yesterday, actually, and I didn't know the answer to this, but atropia, meaning there's constantly there, whereas aphoria is only when it's detected with a cover-on-cover test. So the patient's actually compensating quite well. You can get concomitant or inconcomitant squints, depending on whether the deviation's in all directions or with a specific gaze. Amblyopia is a fancy term for a lazy eye. Okay, it's usually due to a neuronal deficit that has occurred, and so the patient isn't seeing, or the kid isn't seeing properly through that eye. And it's kind of like a subheading of squint, because squints can cause, it's a bigger heading compared to squints, because squints can cause amblyopia, but other things also can cause it, that cause the eye to not receive visual or neurosensory information, such as cataracts, refractive errors, say if they're myopic. So you want to correct for these, and then you will correct the eye. If you can't do any of that, and the eye has sadly formed a lazy eye, okay, so the eye is no longer seeing because the actual atrophy or the neurons haven't formed the right connections due to developmental issues, then you can do occlusion therapy up to the age of 8. And I think there are certain studies saying that you can actually use it further, but for the purposes of the exam, I think up to 8 seems to be the rough cutoff. Before, I mean, anything after that will usually be unhelpful, but studies are changing the cutoff day in, day out. Exotropias, esotropias, essentially deviation outwards or inwards. You also have hypo or hypertropias if it's deviating up or down. And then this is unfortunately rote learning, but the different age groups and how they get tested in terms of their acuity. Okay, I'm sorry I can't offer more on that, but glaucoma, very important disease. I think once again, someone asked me not too long ago about whether this was the second most common cause of irreversible blindness or whether this is the first. I can't remember, the statistics do change, but AMD and glaucoma are probably the two major causes for irreversible blindness. They're both chronic in nature, and with time, the person will lose their sight despite medication, because it's a degenerative disease, and we can stop the pressures or the drusen from building up, but we can't change the path. We can't halt the pathology. There's no cure, so to speak. So it depends on which statistics you look at, but AMD and glaucoma are up there. I would say I think AMD's first, glaucoma is second for irreversible causes of blindness, but I'm not too sure. Do remember that glaucoma comes in two forms: open angle, which is where there's essentially no blockage of trabecular meshwork, but there is some form of resistance for some reason. Okay, there's resistance occurring. And closed angle, where there is a blockage. Usually you get this kind of iris Bombay appearance. Basically, there is the ciliary body that's being pushed forward, that pushes the iris forward, and boom, trabecular meshwork gets blocked. Okay, so it's usually related to intraocular pressure, but not always. Okay, there are loads of forms of glaucoma. Okay, so worth reviewing and being aware of them. But the two major forms that you should be aware of for the exam are primary open angle glaucoma, where there's increased resistance to flow, and acute closure angle glaucoma. These two have different risk factors. Okay, there's some common risk factors between the two, but there's also different risk factors that you need to be aware of. And the classic risk factors are usually high IOP. Okay, usually there's a raised intraocular pressure. There's usually a family history. There's usually myopia. Okay, and it's usually precipitated, in particular with acute angle closure, between different light changes. Okay. All right, brilliant. And all the other ones are, for example, secondary to uveitis, because there's debris of inflammatory cells. If you have proteins that are slightly leakier from, for example, symphysis or basement membrane, okay, you get pigment dispersion syndrome or pseudoexfoliation syndrome glaucoma. You might have traumatic, okay. Malignant glaucoma is when you've had a piercing form of surgery, and so there's kind of aqueous misdirection, so it goes backwards instead of forwards. For some reason, you've messed up the flow mechanism. You have normal tension glaucoma, which tends to be more associated with systemic risk factors such as vascular paths and hypertensive disease. So these are the main ones. And rubeotic glaucoma is also important, known as the 90-day or 100-day glaucoma, because if you ever have a vein occlusion, then unless you treat it urgently, remember they're painless loss of vision, so some people don't even recognize it, then you will develop secondary glaucoma to that vein occlusion, because there's neovascularization that's subtle that occurs at the angle. All right, cataract surgery and refraction, which we had yesterday. Once again, I'm not going to do it the best justice, unfortunately, folks, but I'm going to do my best to just give a few brief definitions and understanding to what I expect the Duke Elder to test. I don't think they'd ever ask you to do ray diagrams, draw them out, or spot ray diagrams. At least that wasn't common in our year. But what they can do sometimes, because optics is quite a big topic for part 1 exam, is they might label things in ray diagrams. So they might say, here's the virtual image, or they might point towards the virtual image that's formed through, say, a mirror or something like that, and they say, what is this? or they might say the physical image, etc. So they might ask you to label stuff, but never to recall that much information, I think. When it comes to optics and cataract surgery, the main things to know are usually the definitions and the ways you correct them. I don't think they'd expect you to ever draw the ray diagrams and explain why these things occur, but essentially emmetropia is a normal eye, and it's usually when there's, usually you have to, when you do cataract surgery, you'll have biometry. So biometry is a way you measure all the various factors that are associated with the eye to make sure that you put the right lens into the person. Because if you put the wrong lens into the person, they'll be incredibly unhappy, okay? So biometry is a way they measure all the axial length, the vertical length, the steepness of the cornea, you know, how much distance there's in the anterior chamber to the lens, how much distance from lens to retina. So when we have an emmetropic eye, such as this, there is an alignment or an agreement between the length and measurements of the eye and the refractive power that's produced by the cornea and the lens, okay? It's all balanced. And that allows for the light to pop onto the retina adequately and not oversight it or undersight it, if that makes sense. Ametropia is when there's a mismatch between these measurements, okay? So the refractive power of the eye is either too strong or too little, or maybe the eye is too long or too tall, etc. And these are known as myopia, hyperopia, okay? Myopia is short-sightedness. Distance vision means people can't see good in distance. And the rays converge, they're slightly short of the retina, so they converge earlier on, okay? And don't hit the retina quite on, okay? Hyperopia is when the rays overshoot the retina. It's usually common in a tall eye, whereas myopia is common in a rugby ball shaped eye, okay? Slightly long that way, axial length is longer, okay? And you'll have different lenses, either concave or convex, so in terms of their glasses, to correct for these. So a concave lens, okay, one like this, will correct, I think, yeah, concave lenses like this will correct myopia, despite this diagram not showing it. And convex lenses will correct hyperopia. And you usually can tell if someone's wearing a concave lens, I think, by looking into their, you look at the person wearing the actual glasses and you tend to not you lose width of their, you lose sight of their temples essentially because they're amplified, okay? So that's what this does. This lens amplifies it, and so it allows it to reach the retina in a myopic eye. Whereas in a convex lens, if you look at someone wearing convex lenses, they tend to look a lot smaller in them because there's almost like a de-amplification. So that ray hits the back of the retina essentially. Do correct me if I'm wrong about that, but this is what I remember roughly. And astigmatism is any form of corneal pathology that affects refraction. So essentially the cornea is a very complicated structure. There's parts of it that are steeper than others, etc. And so if there's an astigmatism or some warpage of the cornea, then there will be either a cyclical error, so a cyclical refractive error, so there's some warpage, or it will also not allow the rays to reach the back of the retina. And this can be fixed usually with toric lenses, or these are specific types of intraocular lenses, or you have to have physical corneal surgery or laser to change the morphology of the cornea, all right? Last few bits and bobs, guys. If you just wanted the revision lesson, by the way, you're welcome to pop off here, but I'll just give you last 3 to 4 slides on just a bit of evidence. I think this will just be more for interest rather than anything. I wouldn't revolutionize what you've done for the Duke Elder now, okay? You've done the hard part, okay? Now it's just to cement the knowledge. But in future exams, just because I'm personally interested by this, there's been loads of reviews by scholars and psychologists into how students study. But despite us doing highlighting, reading, and note-taking, it's usually not the best way to study because of the fact that we become passive in our learning. The better way to study is through active learning. So in some cases, you find this stuff works because you're the type of person who has a very fantastic brain that can, whilst you're highlighting or reading or note-taking, you are actively taking in the information. But it is more cumbersome to do it this way, when the best ways, I think, from what I've understood in literature and what other people tell me, is usually testing yourself through pass banks and doing active recall. So like flashcards tend to be a very good way because you're actively tackling the question and you're almost unlocking the parts of your brain or memory that hold the answer to those questions. And it's much more active way of forming stronger neuronal connections. That's the theory, at least. Okay. So some last minute advice to tackle exam questions. I'm sorry if these are commonsensical, but I always appreciated someone telling me the obvious before an exam because I tend to get panicked myself. So I understand where you guys are currently at. Sleep the night before and all the nights in the run up to the exam. So for example, this weekend, I wouldn't worry about cramming the last bits and bobs of knowledge. Try to get yourself some rest. Otherwise, you will be mentally fatigued, despite you thinking you've crammed the last bits of knowledge that you needed. Know your exam details inside out. I know this year it's an online proctored exam. So be aware of the fact that there will be someone looking at you from a webcam, potentially moderating you sitting this exam. So know the rules, and hopefully you've been sent that out in terms of what you're allowed to do and not allowed to do, because sometimes you're not allowed to even deviate from the screen, phone calls in the background, odd noises happening in the background. So know your environment that you're sitting your exam in, because that will keep things calm and at bay and optimize you sitting the exam. Eat a slow release carbohydrate before the exam in the morning. Okay, so that's stuff like porridge, kind of, for example, if you have Weetabix, you know, those big bars of Weetabix, these are slow release carbohydrates, so they won't kind of spike or they won't decrease your sugar suddenly. Okay, you can also go, I think, full English breakfast, but it's probably more of a spike rather than a slow release carbohydrate. So go for something that you're familiar with and that won't affect your GI system, but eat something that's slow release. Exam questions can sometimes be deduced by a process of elimination. You're all bright students and everything like that, so I'm sure you guys have gone through the process of MCQ testing and everything like that already as part of your medical school training, but the answer's there somewhere. And even though you've reached a complicated question, do try and rule out the ones that you do know for sure aren't the right answer. And sometimes you get to the last two questions, the last two answers, and you're like, go with your gut at that point. Okay, you can always hopefully get down to the last two and then just go with your gut. Okay, so if those are for the questions that you're not too sure of, attempt every question. There's no negative marking, but be aware of your timing. Okay, and if applicable, in some cases, they might reveal the answer or a certain kind of clue in another question downstream or upstream of the exam paper. So try to use that to help you answer that MCQ question. So for example, I think I've seen cases where you might be asked a question about myasthenia gravis, what antibodies might be affecting here or the pathology, but downstream it says this person's anti-acetylcholinesterase positive for antibodies. What would be your next line of investigation, for example? Something like that. So they might help you synergistically answer questions. So think about that, but I wouldn't overdo it also. Once again, this is just a bit of additional information, and I would not revolutionize what you're doing right now in terms of your learning. And hopefully, if you've been on the email newsletter after each session I've sent out, you hopefully have access to some of these resources and books, okay? But the tried and tested formula for passing these exams, unfortunately, tends to be this book for anatomy, which is Snellen's, okay? Snellen's Clinical Anatomy of the Eye. It's about 300 pages. It's fairly in depth, so you might only need to read certain chapters of it. The general kind of molecular biochemistry, pathology, physiology of the eye, once again, you only need to read certain chapters of it, is the Forrester book, known as The Eye, okay? Once again, you don't need to read, this one's a bit chunkier, about 800 to maybe 1,000 pages long, but you don't need to read the whole book to smash any exam. You just need to know certain chapters well. This is a book that's supposedly meant to simplify optics, but unfortunately doesn't do the best job sometimes. It's still quite difficult to understand, but it's the only go-to text we have, and this is the Elkington book for optics. And other books that you should be using as a supplement, but aren't the go-to to read once again, page in, page out, are usually to kind of highlight your clinical acumen or investigations, especially in ophthalmology, seem to be popular questions. So like visual fields, your Goldman's applanation tonometry, perimetry, you know, all this stuff. You have to form your kind of own notes through passive reading of other textbooks, and stuff like Kansky's is a good name, as well as the Oxford Handbook of Ophthalmology, which once you start training in ophthalmology is the go-to textbook for most scenarios because it's quite portable. All right. So this is your recipe. And then obviously test yourself in between each chapter or each book, or once you start to get a bit saturated from reading or creating notes, test yourself. Okay. This is how you form the true memories and active recall. Last bit on ophthalmology. I promise you these are the last two slides. Ophthalmology is unfortunately a competitive specialty to get into. Not everyone gets in the first time, so never be disheartened. Also, don't be put off it despite what people say. Don't ever be put off any specialty, no matter what happens, okay? If you want to do something and you think it's your passion, put yourself in the position of the people who work in it and shadow them, observe them, and see truly if this is something you want to commit to. And ultimately, you will get there if you want to be there, for example. And ophthalmology is one of those specialties where, unfortunately, the portfolio looks very daunting, but is easily done if you work each year on a specific aspect of it. Okay. Always worth visiting the Seven Deanery, which is the local kind of recruitment site for ophthalmology. Okay. But in terms of the Duke Elder, the main thing that you guys are working towards is a pass, okay, which is in the top 60%. Hopefully you can see that you get 1 point in terms of your prizes and awards if you pass the Duke Elder. I'm hoping everyone who's attended this course and seen the videos gets to this stage with just a teeny weeny bit of reading on the side. Okay, that's my hope. But this is what you guys are working towards, and perhaps some of you will achieve this, so even bigger congratulations. Okay. And then I ask you the question, are there easier ways to get prizes than sitting the Duke Elder? Yes, there are. So look into those ways of getting those prizes also, such as presenting a poster and winning regional or national meetings for poster presentations, or prizes for essays also are quite common. Okay, so that is it. That is the end of an era for our 9 webinars on how to slam dunk the Duke Elder. I'm sorry for the corny ending, but I really do appreciate you, every single one of you being here and giving us the privilege to teach, because we thoroughly enjoyed it from our end. All right, and I'm happy to answer any questions, but if you guys are most kind, I would really appreciate some feedback for this course, just so we know whether we run it next year again or we don't, etc., or what we need to modify to make it a bit better